Welcome everybody to this Your Intervention interview. I'm Nicola Ryan, and it's my great pleasure to be joined today by Javier Escaned. And our plan today is to discuss the recent EAPCI Consensus Statement of applied coronary physiology for the planning and guidance of percutaneous coronary intervention, which was recently published in Your Intervention. So welcome, Javier, and thank you for joining me.
Thank you for having me, Nicola.
So obviously you're somebody that has been involved in physiology since the very beginning, since the DEFER study. Can you maybe, before we talk about this paper, tell us a little bit about why you and the group felt it was important at this point in time to update the consensus on physiology?
Sure. Well, the reason is because physiology has evolved from a technique to, in a way, set the indication for PCI to diagnose that there was obstructive coronary artery disease that was causing ischemia, to play a very important role in planning and guidance and guiding PCI. This is the real reason. And the reason for that is because over the last 5 years, we learned that despite setting a proper indication for PCI, what followed is that in many occasions we were leaving behind obstructive disease, and that this had to do with either improper planning or perhaps the fact that we were just being misled at the time of performing PCI, not obtaining the full benefit of having a tool that could help us to optimize PCI from a physiological standpoint.
Brilliant. And nicely in the paper, you've broken it down into sort of 3 key areas: the pre-procedural planning of our PCI, or not PCI as may be appropriate, then improving how we carry out the PCI, the precision of it, and finally into optimizing our PCI or assessing our post-procedural results. Can you maybe briefly talk us through each of the 3 areas, obviously starting off with the planning?
Absolutely. Well, of course, planning of the procedure is extremely important, even more now that we have also image-based physiology technique, that can be applied to CT angiograms. Many of the patients that are coming with chronic coronary syndromes, they already have a CT angiogram, or that even to invasive angiography itself. And you can already obtain lots of information on the phenotype of disease that these patients have, as well as from longitudinal vessel interrogation, making pullbacks with pressure guide wires. We have learned that it's very important not only to know that there is obstructive disease or that there is flow limiting disease, but also to understand if this phenotype of obstructive disease is amenable with PCI. We have learned that if this is caused by a diffuse disease, the chances of PCI to improve the hemodynamics of the coronary arteries to ultimately to fulfill the role of removing flow limiting disease can be hampered. So this is the first step, being able to understand what is the phenotype of obstructive disease, and then predict what is going to be the result of the intervention, and then deciding if you anticipate a good result to move forward to perform the PCI.
Perfect. And obviously, once you've planned your procedure and carried out your essentially precision PCI based on your physiology, how can we incorporate the result into optimizing the outcome of the PCI?
As you say, the way of improving precision is that not only localizing the segment that accounts for hemodynamic impairment, but also to correlate it nicely with the angiogram, so you know that you are treating the right place. Otherwise, you may rightly identify that there is something wrong, but stent the wrong place. And this is largely facilitated in the terms of invasive physiology by techniques like co-registration of physiology with angiography, but of course with any of these what we call functional coronary angiography techniques, QFR or FFRCT, etc., you can already know in the coronary anatomy, which is the segment that you have to treat. That is the precision part. And as you say, it is always important to verify at the end of the procedure, once that you have performed the intervention, that you have accomplished, that you have achieved the functional result you expected. there may be reasons not to be successful in the first go. For example, you may have in calcific vessels improper expansion of the stents, causing flow limitation. And in any case, what we always recommend in this situation of optimization is to use also the concourse of imaging. Intracoronary imaging is very important. We highlight in this document that optimization is both a role for intracoronary imaging and also physiology.
Brilliant. As I said, you've seen a huge evolution, and we've all seen a huge evolution in the field of physiology over the years. Where do you see things moving in the future?
Well, I think that, the arrival of all these functional coronary angiography techniques may have a disruptive effect in favoring adoption of physiology to plan and to guide your interventions. So, in many, the Favor 3 China, for example, is a study that has demonstrated that compared with the routine use of angiography, adoption of coronary physiology with QFR, which is something very simple, something that you can incorporate easily to your workflow, may dramatically improve the patient outcomes, when they are guided with physiology. And I think that, again, we are moving to a new era. Perhaps the most, important challenge is that by making this proper planning of the intervention and predicting the results of the intervention, I'm sure that there will be a number of cases where we will know before embarking in PCI that this is not the tool to treat these patients because the disease pattern is not amenable with PCI. So I believe that we are going to be selecting more and more of our patients, which of course is the best way of improving ultimately the outcomes of PCI.
Brilliant. So thank you very much for joining me today. And I really encourage anybody who hasn't done so to download the paper from your intervention. It's a really useful paper, really practical, lots of tips and tricks as to how to integrate this physiology into your own clinical practice. Thank you very much.
Thank you, Nicola. Great pleasure.